Okay, so we'll have to move on to the next speaker. I want to welcome and introduce Dr. Waleed Alharbi. He's going to talk to us about mitral valve and valve replacement. Please welcome Dr. Waleed.
I will propose to Dr. Fawaz that from now on we need muhallil at the table. There should be a surgeon at the table, I think.
Assalamu alaikum jami'an. So I'm going to talk about a feared procedure that we don't do frequently, the transcatheter valve and valve or valve and ring or valve and MAC in the mitral position. And I just want to have a disclosure that I've only done 9 cases so far, so I'm not the expert, probably like Dr. Mohammed Al-Ataibi. So the outline, I'm going to talk about why we do mitral valve and valve or valve and ring or valve and MAC, what are our goals of this treatment, what is the basic fundamental planning for this procedure, utilizing the mitral valve and valve app, the procedural stepwise tricks and tips, and trying to finishing the complication that you might face. I'm going to show you a complication that I had with one patient. It's a pretty interesting one. So just vote. Who done a mitral valve and MAC in his career? None? Okay. So that's the reason I'm going to show you the complication we had. So, each one has a different mindset in how to approach valve and valve or valve and ring and valve and MAC. And why it's important, because sometimes you need to really eliminate your goal to eliminate the mitral regurg or mitral stenosis. At the same time, you want to minimize the risk of LVOT obstruction when doing this procedure, and you have a minimal risk of paravalvular leak. So those are 3 goals you want to do. And the reason we're doing it is we know from the surgical mitral valve replacement literature, 1/3 of them will need a redo in 10 years. And redo mitral surgery really entails significant mortality, about 10%. And there is change of practice to surgical bioprosthesis from mechanical valve over the years, from 32% in 2000 to 63% in 2009. Hence, the surgeon might refer to you and entertain the option of percutaneous. So we'll start with a case, and we take that case with the steps, the technical steps for the procedure. 82 years old gentleman, known bypass. He has a bioprosthetic mitral valve in 2010. He has severe LV dysfunction with an ICD, AFib, and he has a CE Paramount Magna 7000 size 25. And if you look at the valve and valve, he would fit for a 26 S3. So first step is identify the mechanism of failure. It's very important. And it's either one of those 4 bioprosthetic valve dysfunction. And you need to make sure you're not dealing with infective endocarditis or a thrombus. And the main tactic that you need to deal with is structural valve deterioration. And you make sure before you, like any procedure, make sure there's no absolute contraindication, like infective endocarditis, although there are some case reports have done. Dehiscence of the bioprosthesis is a different animal. Thrombosis of the bioprosthesis, or you have a thrombus in your septum that sometimes you anticoagulate before you embark on that practice. The second step, you want to identify the valve, the ring, and the mitral annular calcification arc. Because of that, you need to use the valve and valve app based on that. So you need to have the OR report. And everyone has a different way and different depth of implanting it. Third, choosing the valve size. And that's where valve and valve mitral helps in choosing that, and also direct you what is the depth you should be on. And the valve sizing, based on this in vitro testing, you'll decide based on that. I'm not gonna talk about rings and bands. Dr. Bandar Shehri did a great job yesterday presenting about how to implant, what are the types, and how you do the sizing. So here we show you where the implant should be based on the valve that we had. And the first step, you want to assess the risk of LVOT obstruction, and that's where CT really helpful, CT planning. So in the part of your CT planning, you want to look at the new LVOT. You want to really you try to avoid the risk of LVOT obstruction by measuring the area, the distance, the angle. All these are really important when dealing with that before embarking on a valve-in-valve. And there are 4 elements for LVOT obstruction. You want to look at the cavity and the LVOT size. You want to look at how the mitral valve leaflet, interior one, how elongated in case of rings, and the angle, if it's really acute, the mitral aortic angle, and the extensive calcification in the subvalvular apparatus. This is where you do the simulation for the new LVOT CT planning to make sure you want to do different simulation about the depth, whether you plan to do 50 or 80 based on or what platform you're going to implant on. Let's skip those. And then accesses. So it's preferable you do, there's no evidence on that, but in a valve-in-valve, the risk of embolizing is very high. It's a good practice to use a cerebral protection device. It's just off-label use in those cases. I do the same thing for some cases for the Watchman. Primary access, you want to have a 14, 16 French wide femoral vein. One of the things I've learned from my colleague, Dr. Bandar Shehri, that rather than using that in case you want to take out the valve and change it, it's better just to put a gore sheath that is 20 French, so you avoid that practice. Use a left radial artery to put your LV pigtail, and a transvenous spacer as a backup, 5 French. You don't need to pace in valve, except in few situations I'll tell you about. Then the transeptal puncture. It's a good practice to use CT to identify your puncture, but in general, you know your mitral valve, it's interior, so you go posterior, so you can go to that area, and you try to go mid to mid-inferior. But that can be changed based on your CT because of the heart orientation, especially post-surgery. Then you're gonna do the puncture, you're gonna cross the valve, you're gonna use the Argillus sheath to direct your pigtail. And before that, and after this, you're gonna do the septostomy. I do it routinely. I don't wanna struggle during my positioning, especially with the movement within the valve. It's not easy. It's a very millimeter movement, and it's a dancing between you and your assistant to implant the valve properly. So take out that equation. Dilate, I usually 18 to 20 balloon, and make your life easier. Sometimes you think it's easy, but it gets stuck. Very difficult to move backward and forward. So there are some tricks. That's why septal puncture is very important, as in any other left-sided transeptal procedures. Sometimes you really get stuck. In this case, for example, very difficult, and that's the key where your pusher should not be withdrawn unless you make sure that you're in the right position. And you should not withdraw it, as alluded yesterday, beyond the septum. Sometimes if you have difficulty, it's a good practice to do flossing technique beforehand. You balloon with the same septostomy balloon. Try to floss the path so make your life easy, rather than struggling like the first case I showed it to you. Make sure your valve is mounted antegrade. and that's your assistant going to do that to double check on that. Next is positioning the valve within the valve. And it's really, sometimes you feel it's easy, but sometimes it's struggling. And the key here, when you put your Safari or any stiff wire, that you put it in the opposite way we do in TAVI, where you flip the coil on the downsides. You try to find your optimal fluoroscopic angle, where you're going to be, you avoid the parallax of your surgical valve. And then you see how the rocking, you really have to go very slow and take your time and with your colleague to try to position your valve before you inflate. Take your time, do it again until you get the right place, and then inflate. Even during inflation, you really take it, make sure, like a carpenter rule, measure twice and then do it. So you see the challenge here, how you really need to go really slow, and you have really good dancing with your assistant and how to deploy the valve based on the depth that you had in the valve and valve app.
Right.
So that was good, but I'm going to show you the dark side of things that might happen. And this is what we learn from. And sometimes, for example, in this case, you see where the ring, it's really difficult to position as you really want it. I was trying to hitting a 20-80, but it did not as I want. Most of the time, the valve going to migrate in the atrial side rather than ventricular side. So here I didn't get what I wanted exactly, but it went. There was no issues regarding from hemodynamics. But remember that most of the time it's going to really migrate in the atrial side. And usually complications, whether you're going to do this, you need to be ready. And usually complications either because of patient high risk, inexperienced operator, or device issue. And those are three things that you need to tackle it. And I'll show you this valve and MAC. So here the arc was adequate, it's about 200, but I'll show you here what happened. Sorry. Oh. Dr. Mohammed Al-Ataibi, is it good position or no? Why?
I think you went ventricular. You went too much ventricular. I can't see the interaction between the TAVI and the Edwards, you see. And this is I'm sure we prepared the whole necessary 3D. This is only unidimensional, but you need to see it in multiple views. But I don't like it. It slips down, and elevator obstruction is a big terror in these type of cases.
So,
sorry, Waleed, but sometimes if you are not sure, if we fear, and we should fear the elevator obstruction, that's why I think valve and MAC is, for me, is shouldn't be done. Generally, shouldn't be done. But if you fear that, I will put a balloon, I will put an access to the LV, and I will put a balloon in the pre-existing TAVI valves. It's in case if I needed really to push it away, it might work.
So good point. So the CT analysis, I didn't show you because of the sake of time, but in the CT analysis, it showed that we're far away. We're very safe to put it in. And I felt that is a good position to me, but before I take out everything, oh, finished?
2 minutes.
Just 1 minute. Yeah. Because I never did this 3 valves in one setting. I'm going to show it to you. So in few seconds, after inflating the balloon, the valves start to migrate atrial. If you look at the position now, it's moved compared to the previous. So I was worried that it's going to even further move. And we put another valve to really try to position it more ventricular in the same way. I don't want to go really ventricular to cause LVOT obstruction or compressing on the TAVI valve. So far, still, I'm trying to avoid, I wished it to go more ventricular, but it didn't. It start to move, you can see how the movement is rocking. But in almost the same position. It's moving even further. If you notice here, it's more clear with the cine. It's moving more atrial. So what would you do?
Over balloon.
We put in a third valve. And we see it, but we didn't save it, but it's moving. And hence, now we're going to take the risk, we go deeper, and accounting for the foreshortening.
حط الثالث. الثالث بتاعته.
Sorry, 3 seconds.
Go back, yes. Yeah. We need to see the video, please. It's now, we are interested, it's not him who's presenting. We are interested.
And finally, it didn't move after that. And the gradient 6 with 3 valves from 13. But I'm just telling you the dark side of things that might happen. And I agree with you, but we didn't have an option. The patient really symptomatic, maximize heart rate and everything, but we had to do it. But I wanted to know, I didn't want to show you successes, but this is really a very difficult case that I've learned a lot from. I wish you enjoyed it. Thank you.
So this was a fantastic talk, Dr. Waleed. We had a similar experience with the valve sliding towards the ventricle. When we looked back at the CT, there was lots of pannus. So when you have pannus in the mitral valve, you get what's known as a watermelon seeding phenomena, where the valve can get ventricularly, and then we had to add another valve. But I guess it's an anchoring problem in your case. Valve and MAC is very complex. As Dr. Alharbi very nicely showed, when you look at the high volume centers, the 30-day mortality, despite valve and MAC successful procedure, is between 10 to 20%. So it's an off-label use, really high-risk patient population. I want to ask Dr. Ahmed, our cardiac imaging expert here from the Cleveland Clinic. So the CT scan is the gold standard to assess for the risk of LVOT obstruction. Is there any utility or benefit to use TEE to assess the risk for LVOT obstruction for those cases?
So pre-planning for the if you're talking about pre-planning for the procedure, So CT is ready to go. The important thing in the CT to simulate the end systole, where the ventricle is the smallest, and the cavity is what you have at the end. So you have to predict. So a radiologist might not give you the full answer, especially the pap muscle going into the LVOT, the angle, the area, as Dr. Waleed said, the area of like 2 centimeters square. But at the end is you need to have, for our planning, is we do a 4D CT. 4D CT that we do all the phases of the CT scan so we can see what happened in systole, what happened in diastole, and you see the rocking movement of the bioprosthetic valve. So you see that rocking movement, you plan for the PAP, you plan for the area, not only the area, the new LVOT area. So you kind of have an idea. Some software now give you a simulation of the valve, but at the end is, again, for every center, there's a learning curve, as Dr. Waleed said, is like, it comes with time, the sense of putting a valve on valve, but again, I would recommend even the radiologist give you the green light, have a sense from an expert aside.
So final question, and then we'll move to the next talk.
Yeah, thank you, Waleed. So, quick question: do you have any experience with valve in incomplete ring, namely Edwards band? Because there's a lot of surgeons out there they do incomplete bands. Incomplete ring.
No, I didn't do incomplete band issue, the paravalvular leak issue, but I wanted to do with a case with Dr. Talal once, but the heart team was not in agreement, which I understand. It was,
How about panelist? Any experience with the valve in incomplete ring?
So it depends on the C ring. Is it rigid ring? Is it what you expect to have? So different rings, different behavior after you put the valve. We've seen it done in the US, but again, it's very risky for paravalvular leak. I mean, some case they put a paravalvular leak plug, but at the end it depends on the valve C shape.
and the data, if you look at the Mayor Guerrero registry for the valve and ring, there's really out of proportion of embolization during the procedure, and that's why people are shying away from that.
Thank you very much. Excellent cases, Dr. Waleed. My question about using of peripheral IVL shockwave in cases of MACs. There are some few cases reports, and the rationale to use it basically to modify the calcium, then probably having a good expansion and basically alignment of the valve. Any comments about that?
I have no experience in that, but our colleague Sami Nasser, he's in St. Mike's in Toronto, and he did publish a series about using that technology. But I have no experience in that, but it would be great to invite him for the next conference to give us his experience.
So we were discussing DCB for the mitral valve. This is the new thing.